Hi, and welcome to Region VII Zoomcast, where we conduct interviews with our Region VII colleagues to learn the perils and pearls related to the COVID-19 response in hopes of sharing lessons learned and also learning something new that we can all benefit from. I'm Dr. Angela Hewlett. I'm an infectious diseases physician at the University of Nebraska Medical Center. I'm also medical director of the Nebraska Biocontainment Unit, and I've also been directing the COVID infectious diseases team here at Nebraska Medicine for the past 18 months. So I'm well acquainted with COVID, whether that's a clinical presentation or these variants that we're going to talk about today. So today I'm going to talk with Dr. Baha Abdalhamid, who is one of my colleagues here at University of Nebraska Medical Center, and we're going to speak about COVID variants and some other hot topics. So let's get started. Welcome, Dr. Abdalhamid. Can you please begin by just telling our listeners a little bit about yourself and your role in the current pandemic?
Yes, I am Baha Abdalhamid. I am assistant professor at the Department of Pathology and Microbiology at University of Nebraska Medical Center. I am also the assistant director of Nebraska Public Health Lab. My main interest is in the methods of diagnostics in infectious diseases, and I am currently leading the team of COVID-19 next generation sequencing.
Okay, wow. So that's quite a bit actually that you're doing, and thank you for your work in that for sure. So first of all, let's just get started, and we'll just start with the basics. So what is a variant?
Okay, well, a variant is a virus that is similar to the original virus, but not exactly the same copy of it. Viruses always replicates to make thousands of copies of themselves. And during this replication, which is fast and messy, there are potential for mistakes in its genetic coding. And these mistakes or changes results in something called mutations. So the variant is basically a virus that is similar to the original virus, but that have a few mutations. Those mutations can be either single or multiple mutations.
Okay, so why do we care about variants, and what does that really mean as far as how does that translate to, say, what we would see in a patient? Why does this really matter?
Well, it's really important to know about the variants. If we take this COVID-19 pandemic as an example, every few months or few weeks, there is a new variant. As we notice, these new variants enable the virus to spread faster from person to person. They can be more contagious, more transmissible, and they are associated with more severe diseases. So more patients will go to the hospitals, and probably more patients will go to the ICU. For example, if we compare the Delta virus, which is the newest variant of the virus, compared to Alpha virus, it's more transmissible and more contagious, and Alpha virus by itself is more transmissible and more contagious than the original virus of Wuhan back in 2019. That's why we need to really care and know about those new variants.
Right, so it's interesting that these mistakes actually go on to produce something that can be worse. I mean, it sounds like each variant that we've dealt with, and I know we've been seeing this clinically, seems to be more transmissible than the original, and then also potentially have a higher mortality rate or cause more severe disease as well. So it's interesting that these mistakes, like you mentioned, can actually lead to some pretty terrible stuff actually. So we hear the term variant used a lot, and we also hear the term strain used as well. Are those the same thing, or is that what's the difference between a strain and a variant?
This is a very important question, actually. They are used interchangeably. So the variant, like in COVID-19, the variant is a SARS-CoV strain also, but they are a little bit different from the original Wuhan virus. They are different in two things. First, as we said, with the replication, there are potential chance for mutations, and those mutations will result in a new distinct physical properties of the virus that slightly differ from the original virus. Like when we say distinct physical properties, we mean like more transmissibility, stronger binding to the human cells, and faster replication. So the variant is like a virus that is similar to the original virus, but they are different in two things: more mutations in there and different distinct physical properties compared to the original virus.
Okay. All right. Thank you for that answer. Yeah, I think that definitely clears up, because I've seen both of those terms used and used interchangeably, like you mentioned.
Yeah.
One question that I know that, I've been asked quite a bit is, this is a coronavirus that we're dealing with. And just thinking about the differences between this virus versus other coronaviruses. You probably heard, people have heard that in the news or wherever, that other coronaviruses exist. And this is true. So there are definitely other coronaviruses out there. Most of them cause something like the common cold. Typically, they're pretty mild disease, usually a runny nose, or, maybe a little sore throat, something like that, but really don't typically cause more severe disease. There are some exceptions to that, and in particular, two other coronaviruses other than SARS-CoV-2 that have definitely, in the last, several years, have caused some, significant issues actually throughout the world. And they act very differently than those coronaviruses that cause the common cold. One of those is actually the original SARS, which actually surfaced in China in 2003. So this is, now we would call this SARS-CoV-1. And there were some cases imported to other parts of the world, particularly there was a large outbreak in Toronto, Canada, associated with a traveler at that time. And SARS-CoV-1 actually was very severe and caused some very severe disease, and actually had about a 10% mortality rate. So this was an incredibly, severe disease, caused very similar clinical symptoms to what we're seeing now with SARS-CoV-2. But there haven't been any cases of SARS, the original SARS, reported since that time. And so it just sort of disappeared and hasn't resurfaced. There's another coronavirus also called MERS, or Middle East Respiratory Syndrome is the name of the disease that it causes. And this is something that actually surfaced in 2012 in the Arabian Peninsula, has mostly been focused in Saudi Arabia, but several other countries in that area and other countries around the world have seen cases due to travelers traveling to those parts of the world. And MERS causes also a very similar kind of clinical syndrome, in that it causes some very severe disease and actually has a mortality rate of 35%. And so if we think about how devastating that would be if SARS-CoV-2, or what we're dealing with now, COVID, had a mortality rate like those coronaviruses, like MERS and SARS. So again, I think, typically coronaviruses cause the common cold, but there are also others out there that are a little more alarming. And we're dealing, I know now, with, SARS-CoV-2, thinking about just the massive number of individuals that have become infected. And so even though the mortality rate is not near as high as SARS-CoV-1 or MERS-CoV, we're still seeing a lot of death and a lot of morbidity, or people getting really sick from COVID or SARS-CoV-2. So let's talk a little bit about how we detect the virus. So how is the detection made with the different variants, and with PCR testing versus how do you determine what variant we're dealing with?
Okay, very great question. First of all, for the diagnosis in the patient, we use two main testing, either PCR or rapid antigen testing, to detect whether the patient has COVID-19 or not. These tests will give you yes or no answer, whether the patient has it or not. But actually, to know if the patient, if this COVID-19 or SARS-CoV in this patient is a variant or not, we need to perform a technique called next generation sequencing, which we know the genetic sequence of the virus, and then we can detect what kind of variant we are dealing with, or it may be just a regular SARS-CoV-2 that is not a variant.
Okay, so sounds like there's some sequencing in, that can be done to determine what exactly we're dealing with. are there certain sequences that actually, or mutations that actually do make this more deadly? I know it sounded like earlier that you mentioned that, there are certain genetic mistakes that can do that. If so, kind of what are they? And maybe explain that a little bit more.
Yes, definitely. There are mutations that make the virus more transmissible, causing more disease, more severe disease, and it might be more deadly. I'll give you one example in COVID-19, mutations in a region that encode the spike protein. The spike protein is part of the virus that is responsible for the viral binding to the ACE2 receptor on human cells. Okay, so there are certain mutations that happen on this protein that result in stronger binding of the virus to the receptor on the human cells. Like in Delta virus, we have a unique mutation in the spike protein called P681R, which result in strong binding of the virus to the receptor, more fusion of the virus with the human cell, which result in more invading of the human cells and more transmissibility, more contagiousness, and higher replication rate. In the alpha variant, I'll give you an example of a mutation in the spike protein called N501Y, which also results in strong binding of the virus to the receptor and which gives the virus higher ability to invade human cells.
Okay, so it definitely sounds like that, that these variants and these particular mutations, it just makes it easier for the virus to get into the cells, which in turn can cause people to get sicker with some of these variants, particularly the Delta that we're seeing now. We're definitely seeing people with more severe disease than we saw with the previous variants. So that makes a lot of sense. One thing that I'm also asked a lot is, regarding these variants, what does that mean as far as our vaccines go? Like, we've heard that there's a recommendation that we may all be requiring an additional dose of a vaccination, coming up, probably likely relatively soon in September. And the question is always, what data supports that, and why are people making these recommendations to potentially have people get these, these third doses of the vaccine? And there are definitely data that are emerging that show that immunity from vaccination does wane over time, and frankly, so does immunity from natural infection as well. If you had actual COVID, the disease, your immunity, you may have some immunity for a period of time, but it does tend to go down as time goes on. And we're seeing that people that were earlier vaccinated, so some of our healthcare workers and elderly folks and people that got their vaccines early, usually around January of 2021, the studies have been done that actually look at whether they still have a lot of immunity. And, it does show that there is definitely still some immunity for vaccines, from vaccines being produced at these later time periods. So after several months, even up, 6-8 months later, but it does seem to be less than initial immunity that was, produced, which makes a lot of sense, actually. When you get your vaccine, you have this big immune response, and then, but over time, those antibody levels may wane and or go down. And when that happens, then you may not have as much protection from the shots or from natural disease as you did when right after you first got your vaccines. And so it's also really apparent that the Delta variant is very different, and it is infecting some vaccinated people, some people that are fully vaccinated, although they do tend to have milder disease and typically don't require hospitalization and don't go on to have severe disease or die from the illness. And so it does appear that vaccination is still very protective from those more severe consequences that we know about with COVID, but it does seem that protection does go down over time. And so studies have shown that providing an additional dose of the vaccine does boost antibody production quite a bit. And so the reason for the recommendation for an additional dose is to really try to give people as much protection as possible from the Delta variant and from COVID in general. So, question again, will vaccines continue to be effective? I mean, we're still learning a lot about how long these vaccines protects people from COVID. We're learning more every day, honestly, about this. And it really looks like there's still a great deal of protection provided by the current vaccines, especially, as I mentioned, from severe disease and from death. But this could change as new variants develop. And that is something that concerns all of us, is will the next variant be more severe even than the one we're dealing with now? So what can we do to stop the spread of variants? This is something I also hear a lot. Why do these, we're hearing about how they develop, but how can we as humans and as a population really put a stop to this? And really the most important thing we can do to stop the spread of these new variants is to control the spread of COVID in our community. And the best way to do that is to have people get vaccinated and have a large percentage of our community be vaccinated, because that's really the way that we can protect our entire community from these surges like the one we're experiencing now. There's also some urgency to this, given what we're experiencing now with the surge and the fact that we're seeing so many more new cases, particularly with this Delta variant, and also people that are becoming very ill from this. And so there's some urgency for people to get vaccinated now. And along with vaccination, there are other layered interventions that can help as well. So things that we've all heard about, like masking, particularly if everyone is masked, because that way it provides source control. So if someone is infected, particularly with this Delta variant, which causes high viral loads in the nose, if someone is infected, they provide some source control to help other people. And then also you can use the mask to protect yourself as well, especially a high quality mask. But those layered interventions, so masking, distancing, particularly not gathering in large crowds, favoring outdoor activities as opposed to indoor activities, which increases ventilation, makes things, things safer. Hand washing, of course, those can all contribute to stopping the spread of this virus in our community, and then hence not allowing these variants to continue to form. So, are there new vaccines under development? We know right now there are 3 vaccines that are in use in the United States, and there are a variety of different vaccines that are in use across the world. And in an attempt to stop the spread of COVID-19, currently in the US, we have the Pfizer vaccine, the Moderna vaccine, and the Johnson & Johnson vaccine, but there are also multiple vaccines that are still in development and in clinical trials. And so it is possible that we'll see more vaccines and have more options in the future regarding vaccination for COVID or SARS-CoV-2. So let's talk a little bit about what we think about these new variants and what we expect them. Do we expect them to be stronger in their ability to infect and make people sick? I know you mentioned that earlier, that's what we've seen with Delta. Do we think that the next variant will be even worse?
Well, yeah, actually, we need to keep this in mind. There are 2 events that are going at the same time. The first, that the virus, as we said, keep replicating. And as long as the viruses keep replicating, mutations will occur. Okay. The second fact, which is good for us actually, more people are getting immunity through either through infection by the virus or through vaccination. And this is growing immunity rates provide kind of evolution pressure on the virus to keep changing, and that will help the virus to evade the immune response. So that's why we need to keep in mind the new variant might be either more stronger and worse than the previous variant. Let me give you an example. Delta variant is more transmissible and more contagious and associated with more severe diseases compared to the Alpha variant or Beta variant. So it's possible that the new variants may result in more contagious variant, and that will make people even sicker.
Okay, all right. Well, that's something we obviously need to pay attention to, because we feel like we're overwhelmed right now with what we're dealing with Delta. Imagine if we had a variant that was even more severe or even more transmissible, which is hard to imagine actually, given what we're seeing with Delta and the amount of people that seem to become infected after exposure to an infected individual. But it's possible. And that's something that we really need to pay attention to. And people like you, obviously, who are working in the laboratory setting and really kind of on the front lines of laboratory medicine, are really the ones that are able to spot these these new mutations. And so we definitely appreciate your work and all of that for sure. One question that was submitted is, do COVID symptoms change with each variant? So are we seeing different clinical things with the different variants? And most of the symptoms that we've actually seen from each of these variants have really been similar. I mean, some of the common symptoms of COVID, as we all know, include, things like fever, chills, body ache, sore throat, cough, sometimes difficulty breathing, loss of taste and smell, which is something that really has become, I mean, if you're losing your taste and smell right about now, you can pretty much say that it's COVID until proven otherwise, because although there are some other causes of that, that's something that we're seeing as a real kind of hallmark of some of these cases, particularly the ones that are milder infections. Sometimes patients also have nausea and vomiting or diarrhea or some other kind of gastrointestinal symptoms that develop. And we've really seen very similar symptoms. Now, as was mentioned, what we're seeing, though, is more severe disease associated with the Delta variant compared with what we saw in the past. So as opposed to, the previous variants where there were more people who had milder disease, were able to stay home, maybe they felt poorly for a while, but never really required hospitalization or needed oxygen or any of that sort of thing. We're seeing more of that with the Delta. We're seeing more people who develop severe disease. And the problem that I've noticed for sure is that we don't really know, you don't know which category you're going to be in. So you can be an otherwise young, healthy individual with no other medical problems with this Delta variant and actually get very sick and come in the hospital, even require mechanical ventilation, lots of oxygen supplementation, and even die from this. So this is something that we saw some people with the previous variants who became very ill like that, but most of those people were people that had lots of other medical problems or were very elderly or immunosuppressed. We're still seeing some of those people with Delta who get very sick, but we're also seeing younger people. And that's actually very alarming to me, that if you're otherwise healthy and don't have any medical problems, you still can acquire this disease and get really sick from it. So how does we mentioned earlier, vaccine immunity versus acquired immunity from the disease itself. So how does that relate to the different variants and what are we seeing? This is a real hot topic right now. Both vaccines and natural infection do produce some degree of immunity, as I mentioned earlier, for a period of time. But as I talked about earlier, that does wane over time. So in other words, the amount of immunity that you have and the amount of protection that you have definitely can go down. And we're definitely seeing Delta variant, when it came in, it really did start to infect some people who were vaccinated, some people that had had disease before. So if you had natural COVID infection back in fall of 2020 or something of the like, we're definitely seeing those individuals still becoming infected with the Delta variant. And so far, the scientific evidence seems to favor vaccination as producing a stronger immunity compared with natural immunity. But this could change, and this is definitely a topic of discussion that is ongoing right now. Another topic of discussion is whether people that have actually had COVID disease itself should receive one dose of vaccine and could still produce strong immunity from that, because they had, the actual COVID disease, got some immunity from that, and maybe they get their sort of boost with an additional dose of the vaccine compared to people that have never had COVID and require the 2 or more doses. And this issue is really evolving, so I would just stay tuned because we're learning more about this every day. So do variants always lead to stronger versions of the virus, or is it possible that it can actually weaken and stop infecting people? So I know you talked about the virus, with like Delta, for instance, because it's easier for Delta to come in and infect the cells and actually easier for people to get infected. Could it go the other way? Could it be where one of the new variants actually became weaker and maybe produced milder disease or didn't infect as many people?
Well, this is a very important question. Actually, it can go both ways. As we mentioned before, like alpha and delta viruses are associated with more severe, more transmissible, more contagious cases. And the way the virus progresses so far tell us that the new variant might be stronger than the previous one. Like, as we said, Delta is stronger than Alpha. But there is some hope. Actually, we had a case last spring. In March 2021, we received cases from a long-term care facility. Those are elderly people. Those are high-risk group to be infected by COVID-19. And we received actually 7 samples from those asymptomatic individuals. They were COVID-19 positive by PCR, but they did not have any symptoms. So we were really surprised because those are a high-risk group and they don't have symptoms. So we did sequencing for these viruses, and fortunately, we detected 2 novel mutations in this variant. First of all, the 7 individuals had the same exact virus. And this variant of the virus have 2 novel mutations that result actually in reducing both the ability of the virus to establish infection in a human body, and also it reduces its ability to suppress the immune response. That's why those individuals were asymptomatic. So there is a hope that hopefully in the future we'll get a new variant that is weakening the virus, and it may end the virus itself, like what happened in SARS-CoV 2003.
Wow. Okay. That's really interesting actually to hear that. And because that is the population, particularly, the elderly, people with lots of medical problems, that was the population that early on we were very concerned about, because if you had that many people becoming infected, typically, those folks would not be, without symptoms, and sometimes they would go to the hospital and sometimes they would even die. And so it's, it's interesting to know that, that a variant could develop that could actually make this a milder disease. I think we all, hope that something like that would happen, where this would be more like a common cold. And whether we achieve that by, continued vaccination, or whether the virus pulls some tricks out and does something different. We hope it goes that way and not that things get worse. But yeah, I think only time will tell, unfortunately. So.
Yeah, actually, one comment on this, because that was like really a very exciting case for us, and we gave us hope for a weaker virus. We wrote a case about this situation, and we published it in JAMA Network, actually.
Okay, excellent. All right. No, it's good to get that information out there for sure.
Yeah.
So, yeah, good. Okay. Well, we hear a lot about resistance in bacterial infections, resistance to antibiotics, that sort of thing. Is this something that could happen with COVID and some of the treatments that we're using? Could there be resistance that develops? And the answer to that is yes. Bacteria can certainly become resistant to antibiotics, particularly if they're misused. And this is why we're always told to, take all the antibiotics as prescribed, and to make sure and finish taking all the antibiotic pills as recommended, because that's the best chance of clearing the infection, but also of not creating that resistance to the antibiotic along the way. A virus can actually develop a mutation or a set of mutations that actually does create resistance to different antiviral drugs. And we've seen this with other viruses, particularly with things like HIV, herpes viruses. And, as that virus changes, it can cause certain drugs to not work as well or not work at all. And so this has already actually happened with SARS-CoV-2, in that we had some drugs that we were using and are still using called monoclonal antibody cocktails. And these were used to treat people with early symptoms of COVID who were at home in hopes that they would continue to have mild illness and not have to go to the hospital, not get severely ill. And these cocktails have had to be adjusted actually over time because the early forms of the cocktail that were being used don't work on these new variants. And so we're having to sort of change change the type of monoclonal antibodies that are used in order to make sure that they're still effective against new variants, and particularly Delta now. And so, as I mentioned, viral resistance is not something that is unheard of. We definitely have that with, and see that clinically with other viruses. So it's really not surprising that we're also seeing that with SARS-CoV-2. So another question that's very common is, will the COVID virus or SARS-CoV-2 be like influenza? Will we need to get vaccinations every year? And really, this is not well known yet. I mean, we've already talked a bit about immunity and the waning immunity that sometimes occurs or has been known to occur after vaccination or after natural disease. So it's certainly possible that booster shots will be needed in order to provide ongoing protection against COVID, particularly from these new variants that we've been talking about. As the variants change, then we may need to adjust our plans for vaccination. So the frequency of that is not really clear yet. Is this going to be an annual shot like influenza, like we get our flu shot every year, or will it be every other year? We really don't know that yet. But studies are definitely being done looking at the amount of protection that these vaccines continue to provide over time. And I do believe that there will be some booster shots needed, as we've already mentioned. That's really up and coming, relatively soon, probably in September, now with a recommendation for a potential third dose of the mRNA vaccines. But we'll see. We'll see how this goes. There's definitely a chance that we will need ongoing vaccination at some interval. It may not be as frequent as the flu shot, but that's yet to be determined. So what are the chances that we actually will get rid of this virus? Will we be able to eradicate this virus like we've done with smallpox? And really, based on what we know so far, it is possible that this virus will be with us for a long time. As we've heard, these mutations continue to develop. We have, new variants that surface. But what we really need to do is to have people get vaccinated in order to minimize the spread of the virus. As I mentioned earlier, that's the way that we can stop this, because we can stop new variants from forming by providing protection for everyone. And, the only reason we don't see smallpox anymore is because of vaccines, because of an effective vaccination that came out, and we vaccinated the world. And because of that, we're not seeing smallpox anymore, which is incredibly fortunate because smallpox actually has a very high mortality rate as well. So if everybody in the world gets vaccinated, we may be able to beat this virus altogether, or at least we can make it something that we can live with. We can make it something that would cause a mild disease in the vast majority of people, and just, we wouldn't overflow our hospitals, wouldn't overtax our medical system and cause, have a lot of people who are getting very sick from it. So hopefully that will occur. I mean, if we do have to live with this virus, we need to make it something that does not make people very sick, because otherwise we're going to continue to fight the same fight that we're fighting now, and that is, overwhelming our healthcare systems and having people get very sick from this virus and even die. So the lesson with smallpox was vaccination. Vaccination is what really can help get rid of this throughout the world. And that's all of our goals. We all want to get back to normal. We all want to go back to doing the things that we want to do. And the way to do that is to really get this vaccine out there, not only in the United States, but in other parts of the world as well. So can somebody get sick with a different variant if they already had COVID previously? I think that's a great question for you. Can, if you had COVID before with one of these previous variants, can you still get sick with a different variant? And I think I kind of alluded to that earlier, but maybe you could give us some more details about that.
Yes, actually, it happens, but the percentage of such cases is very low. There are cases of reinfection by different genotypes for the same patient. One of the earliest studies was done in Singapore, where the same patient was infected 2 times by COVID by a period of more than 4 months. And there were the infection happened by 2 different genotypes. That was before we started talking about the variants. Okay, another example now because of the vaccine breakthrough. Okay, we're doing great job on vaccination, and there are several cases of vaccine breakthrough. Actually, we just finished a study about our experience with vaccine breakthrough here in Nebraska in the last 6 months, from January 1st until July 31st. And we have actually around 2,000 cases of vaccine breakthrough. And by definition, when we say vaccine breakthrough, it means that the patient finished the vaccination series, the 2 doses, and he has COVID infection 14 days after completion of the 2nd dose. So actually, we had around 2,000 cases. And interestingly, the Delta virus was the most dominant variant in those vaccine breakthrough, followed by Alpha virus. And what's also actually even more interesting, we have around 30 cases where there was a vaccine breakthrough by a non-variant genotype of the virus. So people can get sick with other variants, even if they have COVID infection before. The vaccine breakthrough in our hands, it's still at very, very low rate. It's around 3%. I don't want people to get panic. It's very low rate. And we don't know actually the medical background for those patients.
Yeah, so that actually goes along with what we're seeing in the hospital and in our clinics, in that, the vaccine still seems to provide an extraordinary amount of protection, even against mild disease, but particularly against severe disease and death. We really are the vast majority of people in our COVID units right now, and we have multiple that are open right now at our hospital, unfortunately, are unvaccinated. And these individuals are coming in getting very sick. A lot of them, as I mentioned, are younger, healthier people, which is very different than what we had seen with previous waves in the past. And yeah, I mean, the real sort of take home message is that these vaccines work. They work to prevent COVID altogether. And in some cases, people may still get infected with the virus, but they tend to go on and have mild cases, which, makes it more like some of the other viruses that we have circulating around, and people may feel miserable for a few days or whatever, and may have to miss work. And that's unfortunate, but at least you don't have to go in the hospital. At least you don't require oxygen. At least you don't need a ventilator, at least you don't die. I mean, these are things that that definitely, those are our most adverse outcomes, our most severe outcomes. And we seem to be preventing those for the most part with vaccines. Now, one group of people that we are seeing in the hospital that can be fully vaccinated are our immunocompromised patients. And so these are patients that have cancer or maybe on chemotherapy from that, have organ transplants or rheumatoid arthritis, and they're on other medications to try to suppress their immune system because of those diseases. Those individuals traditionally don't respond very well to vaccines. Their immune system is just not there. They just don't have the ability to respond to vaccines the way that somebody with a healthy immune system does. And so because of that, even though they are doing the right thing and getting vaccinated, we are seeing some of those individuals in our COVID units, and they get very sick. And it's unfortunate because, like I said, they're trying to do the right thing, but there's so much COVID in our community right now that it's, when they get it, they can get it and actually suffer some of those adverse consequences. And so we really need to do our best to try to protect those vulnerable populations, particularly those individuals that are immunosuppressed. So we've seen different responses to the COVID virus or SARS-CoV-2, with some people getting little or no symptoms at all, or others becoming really sick and even dying from it. Is there a potential for a variant to be more severe for everyone, so that everyone gets the same symptoms and is more severe? And this really, to me, is a very scary concept, but it's definitely possible that a variant would develop. And I think some of the information that we've heard earlier supports that could evade our vaccines, or be overall more severe, kind of like Delta is more severe than the previous variant. So maybe making it more like SARS, the original SARS, or MERS-CoV with those higher mortality rates that we talked about earlier, which, but it's still highly likely that people will have incredibly different responses and symptoms. And so this is true of all other viruses. Not everyone gets all the same symptoms. Some people, may have very minimal symptoms, if any at all, or others may go on to have more severe disease. And so there still will be some variation, I believe, in symptoms, but it is possible that one of these variants could develop that could be a lot more severe than what we're seeing now. And as I said, I do feel like, especially given what is already occurring with the Delta variant with our healthcare system, I feel like that is an incredibly scary concept to think about. So lastly, I think, I've heard this described as alphabet soup, but where do these variants get their names? How are we naming these things? Originally we had lots of sort of numeric names for these things, and now we have the Delta and the Alpha and all of that. Who decides how to name those variants, and how is that decision made?
Actually, this is very important question because the way the nomenclature of these viruses is a little bit confusing. In general, it depends on the number of mutations in the new variants, the locations of these mutations, also the prevalence of this new variant and the geographical location. Let's start by some basics. First of all, World Health Organization, WHO, is responsible for naming the diseases. So COVID-19, WHO decides the name of the disease. For virus naming itself, there is a specialized committee called the International Committee on Taxonomy of Viruses, ICTV, which has virologists from all over the world to give the taxonomy of the virus. And the reason they gave SARS-CoV-2 for this COVID-19 is because of the high similarity of the genetic material between SARS-CoV-2 and SARS-CoV that caused SARS back in 2003. So here where the virus name came from. Now we talk about the variants. The variants actually is a little bit more, it started like informal, like it depends on the scientists or the researchers or the physicians who detected this new variant. Like when they detected the UK variant, it was first detected in UK, so we started calling it UK variant. The Indian variant, okay, we started calling it Indian variant because the physicians in India called it the Indian variant, okay. There are different health organizations that use different types of nomenclature for SARS-CoV. There are three main nomenclature according to the health that is using it. We have the pangolin nomenclature, the A, B, B1, and so on. The GIS-8 nomenclature that gives the virus name by the main mutations that cause this variant, like SOLV and others, and next strain nomenclature that gives the nomenclature based on the year of the detection, and then followed by letter, like 19A for Wuhan strain. Then WHO stepped in to make life easier for all of us, and they came up with the Greek alphabet. Okay, so like now the UK variant is called the Alpha, the South African variant called Beta, and the Indian variant called the Delta. If we're gonna see how confusing it was, like let's take an example, the Delta virus. In India, it's called the Indian variant, okay? According to Pangolin, it's B1617.2. According to next strain, it's 21A. And according to GIS-8, it's GK variant. But now WHO came up with this Greek alphabetical order, hopefully to make all of us on the same page. Here in the United States, we did a great job, actually. The US government has something called SIG, which is SARS-CoV-2 Interagency Group. So there are scientists from different committees in the United States and different organizations from CDC, FDA, NIH, and DoD, Department of Defense, to do classification for these variants. So you're going to hear about variant of interest, variant of concern, and so on. So hopefully with this new nomenclature will make life easier for all people.
Wow, so that's some pretty complicated stuff. I'm glad that somebody thought about making it a little easier for all of us, frankly. Yeah, because otherwise it's just confusing using all these different names. But thank you for that explanation, and much appreciated. So. I heard the reference to pangolin in there. I'm assuming that that's referring to the animal, which was thought to be one of the hosts actually of this virus originally. I'm not, is that the case?
Yes, you are right. You are right.
Okay. And for those of you that have never seen a pangolin, which I had not prior to, or at least I shouldn't say seen in person, but at least looked at a picture of one, you should check that out. yeah, it's definitely go on the internet and look at what a pangolin looks like. But that it is one of the animals that has possibly been implicated in the initial infections or spread of SARS-CoV-2. One thing too that I did want to bring up too, just speaking of nomenclature, and I find myself doing this as well, even though I talk COVID and SARS-CoV-2 all day long, but SARS-CoV-2 is the name of the virus. That's the actual name of the virus that we're dealing with, whereas COVID or COVID-19 is the name of the clinical syndrome. So, we're using COVID all the time, as a name for the virus, but in actuality, it's SARS-CoV-2 is the virus. COVID is what we're seeing in the hospital, and that's people with COVID or people that are experiencing symptoms due to COVID and that kind of thing. But that is something that I see all the time, and I find myself confusing the two every once in a while when I speak as well. So yeah. Any other final comments? Are we good to go? I think we've talked a lot about quite a few different topics today concerning the variants.
Yeah, I think we covered a good part of the questions, and I think I'm okay.
Okay. All right. Well, good. Well, thank you again for your expertise and for joining us. I know people talk a lot about the front lines of healthcare workers, and they think about automatically nurses and doctors and others who are taking care of patients, but in actuality, our laboratory scientists are on the front lines as well. They're really on the front lines of giving us the ability as clinicians to diagnose this illness, to be able to recognize it, using some of these tests that were discussed. And so thank you for all of your work on there and for being on the front line. It's much appreciated by all of us.
You are welcome.
So in closing, we hope that you found something of value in today's conversation and discussion about viral variants and how they can affect us and what the future looks like going forward. We recognize that there are a lot of unknowns still about this, but we're learning every day as time goes on. And, this is something that has really been a part of this pandemic, is the fact that we need to be fluid and think about that, as new concepts and new things are discovered, we need to make sure and be able to go with that and to change, the things that we're doing in order to reflect that. And so, I want to thank our guest today for sure for your time and again, much appreciated. And thank you for all of the work that you do. Thanks to the listeners for listening in. We'd also love to hear from all of you, especially if you know somebody that we should have a conversation with on this podcast, or if there's a topic that you'd like to hear more about. And if you have any questions, please, there's an email address that you can actually send any ideas or questions to, and it's NBU, like Nebraska Biocontainment Unit, NBU at nebraskamed.com. And so thank you very much for listening, and I hope you have a good rest of your day.